Hello and welcome everyone. Today we will hear the latest news, studies and clinical updates in the field of tomographical biomechanical assessment. And on that note, allow me also to welcome and thank our pristine panel of speakers, Dr. Riccardo Vinciguerra, Dr. Abhijit Roy, Professor Lim Li and Professor Rohit Shetty. Thank you for taking time to prepare your presentations and to present to us today. So without further ado, as I mentioned, our first speaker is Dr. Vinciguerra, and he will be talking about pre-operative refractive screening and keratoconus monitoring based on corneal biomechanics. Dr. Vinciguerra, the floor is yours.
So, what is the ideal pre-op screening? It's something that is reliable, that is easy and fast, and is validated. Now let's spend a word about sensitivity and specificity. We want to have a high sensitivity, which it means that you detect all cases at risk, but on the other side, you have also high specificity, so you avoid to exclude too many cases that could be safely treated. And what are our tools? Well, it's topography, tomography, epithelial maps, and corneal biomechanics. We hear a lot speaking about artificial intelligence. How can artificial intelligence help? Artificial intelligence is a wide range of computer science that can help us in performing tasks that normally necessitate human brain. But what about in the field of refractive surgery and keratoconus? They can help detection and progression. This is what we normally think when we hear the word AI. But in reality, artificial intelligence can also be a statistical artificial intelligence, such as logistic regression, random forest, neural network, and support vector machine. You don't really need to know how they work, but what they do is that they kind of help us in separating between one category and the other. For example, risky cases and non-risky cases, normal patient and keratoconus. So what does it mean? It means that we can give the data and feed our artificial intelligence to detect or predict risky cases or keratoconus. Let's see some examples that are used in the OCULUS platform. I'm going to start with the CBI that was published in 2016, and it was implemented in the OCULUS platform, and it was awarded with the Troutman Prize in 2017. The Corvis Biomechanical Index was aimed to separate normal patient from keratoconus. How does it work? You have a cutoff of 0.5. Normal patient will be very close to 0. Abnormal patient will be very close to 1, between 0.8 and 1. Why is that? Because it was created with a logarithmic curve, which means that you will not have many patients in the yellow zone, so between 0.2 and 0.8. They will very quick go from the 0.2 to the 0.8, so you will not have a lot of patients in which you will be in doubt. We also validated this index in the first publication, and then it was subsequently validated in many other papers. The sensitivity for clear keratoconus is around 100%, and the specificity is 98.4. But then you might say, how does it work in clinical practice? Well, let me show you an abnormal patient. This is the Vinciguerra screening report, in which you see the CBI in the bottom right, that in this case is 1. So you can see a keratoconus that goes around 1. But then you might say again, well, you know, I don't really need biomechanics to diagnose keratoconus. Placido disc is enough. So let me show you this case. You can see this one that is relatively thin, is around 510, 505, but anterior and posterior elevation are normal. This is the right eye. You can see that the Bailey Ambrosio is 1.18, so it's absolutely within normal limits. But on the other side, if you look at the CBI, it's 0.99, which is very suspicious. Then you go and look at the fellow eye, which is a clear keratoconus, and of course the CBI is abnormal. But we do know that keratoconus is an asymmetric disease. So most likely this patient that was abnormal in both eyes now might have been subclinical, even in the eye that was looking normal some years ago. So we published quite a lot of cases like this in which one eye was looking normal, but biomechanics was abnormal in both eyes. But then you could say, well, with all these indices, maybe I will not treat many refractive patients. So remember, this is the sensitivity. Now I want to show you that the CBIs also have a high specificity. This is an absolutely normal patient, very thick cornea, just oblique astigmatism. But unfortunately, the Bellin-Ambrosio is 2.45. Some years ago, we might have excluded this patient from refractive surgery. And the left eye is the same, thick, but the CBI is, sorry, the Bellin-Ambrosio is abnormal. However, the CBI is normal in both eyes. This is the stiff cornea, and this patient was safely treated with refractive surgery and is stable after years. So this tells you that biomechanics can help you even in avoiding to exclude patients that are good for refractive surgery. Now I'm going to show you another interesting case. This is a 49-year-old female referred to me for decreased vision and monolateral keratoconus. It was considered cross-linking from another clinic as there was a significant visual loss. So this is the topography where you can see that there is a steepening in the right eye, but the thickness is fine. So that is already something that is, let's say, strange. The CBI was normal in the right eye and was normal in the left eye, and also very symmetric. If we looked at the epithelial mass, you could see that there was a thickening in the epithelium rather than a thinning in what we are used with keratoconus. After asking again and again to the patient if there was anything that she didn't tell us, she said that actually some months before she had an incident with boiling oil, and probably that caused an hyperplastic epithelium. So I suggested alcohol-assisted epithelial removal, and this is the post-op. The patient is 20/20 unaided, and she's back to her normal life. And the CBI and the TBI remain stable even after surgery. But then you might say, well, why do we need to go further? You remember this case, so the one I showed you before. What we want to do is to detect all these risky cases as much as we can. So then we need to combine tomography with biomechanics. That was a paper led by Renato Ambrosio, in which we collaborated with him, in which we created this new index that is called TBI, which is Tomographic Biomechanical Index, in which we aimed to assess if we were able to detect those patients that were looking normal, but the fellow eye was abnormal. And as you can see in the ROC curve, and also in the graph on the right-hand side, you can see that the CBI and the BED are both not enough to diagnose this patient, and the TBI is a significant improvement. This is how it looks in the TBI, tomographic biomechanical assessment in the Corvis. You can see that there is the CBI, the BED, and the TBI, and this is one of those keratoconus. Let's go and see the patient that we were discussing before, the one that are tricky to diagnose. So this looks like absolutely normal patient. Bellin-Ambrosio 0.68, but here you can see that the CBI is 1 and the TBI is 0.75. So this is one of those unilateral keratoconus, in which also the eye that looks normal on tomography is abnormal with biomechanics. And that's the fellow eye, which you can see that is a clear keratoconus. So let me show you this case that is a courtesy of my friend Renato Ambrosio. This is the right eye of a patient that is relatively thin, left eye, Bellin-Ambrosio that is normal in the right eye and the left eye. Unfortunately, this patient was treated with SMILE by Dr. Ambrosio, that we know he is one of the most expert refractive surgery in the world, and the right eye developed ectasia over time. You can see that there is the change in posterior elevation, whether the left eye remains stable. This patient was treated back in 2014 when the TBI and the CBI were not available. But Renato already was doing Corvis to all patients, so he was able to retrospectively evaluate the pre-op of this patient, and he could see that the TBI was abnormal in the right eye. That is the eye that developed ectasia. So now we stopped, let's say, refractive screening, and now I'm going to speak about keratoconus stages, which is an exciting new thing that we did in collaboration with Homburg University that led this staging of keratoconus with biomechanics that I will tell you in a second. So why do we need staging? Because staging provides information about the severity of the disease. Progression analysis instead tells you whether the condition is getting stable or worse. Neither staging nor progression, remember, is intended for diagnosing of the disease. So why do we need staging and progression? Because, for example, the CBI does not give an indication about the severity. It helps you only in the diagnosis. And severity is not only important for patient communication, but also to see whether the patient progressed or if after cross-linking the progression stopped. In the ABCD progression display of the Pentacam, we have only information about the geometry of the cornea, but the biomechanics provides complementary information that will be very useful before there are any tomographical changes. So we decided to include a new index, that is the E, elasticity, as a supplement to the ABCD staging. So what did we do? We created, we wanted to separate like the Amsler-Klumai between the 0 stage and the 1-4 in keratoconus with increasing severity. What did we use? We used this linearized version of the CBI because, as we have seen before, the CBI goes very quickly from 0 to 1. So we needed something that was changing linearly. So that is what we did. And then we also evaluated the confidence interval of the E-staging to be able to tell you if there was a significant change over time in the E-staging. But let's go step by step. So the first thing we did is we linearized, transformed the CBI. If the CBI gets higher, like a patient that is getting worse, the CBIF gets smaller. Smaller values of the CBIF are associated with a softer cornea, and so a keratoconus that is more severe. Then we adjusted the scale of the CBIF to the radius of curvature of the posterior radius of curvature. In this way, we were able to create stages because, you know, when you create a stage, you want to somehow separate between severity of the disease. So we use the posterior radius of curvature to adjust the scale of the CBIF. And that was published in a first paper in JCRS in July 2021 with the team of Professor Seitz and our friend Elias Flokerzi. So these are the stages that were divided. So 594 to 536, etc., etc. Then we needed something to define whether the E stages were getting worse. So we know that the keratoconus cannot regress spontaneously. So then we decided to use the one-sided 95 confidence interval for repeated measurement to judge whether there was a progression in keratoconus. This is how it looks in the beta software that will be very soon launched. So you can see that these are 4 exams. So you can upload up to 4 exams. And then in the bottom, you see whether the change in either the single parameters or the E staging is significant. So for example, in this case, you have a significant progression compared to the baseline. You can see this small orange tick on progression. It's small, but I will show it to you a little bit bigger in a few stages. It's also important to have the single parameters. First of all, because we don't want to trash what we have done before. And the second thing is because patient after cross-linking can also get stiffer. So we need then 2-sided confidence interval to judge whether a single parameter can also get stiffer over time. And now I'm going to show you some examples. But before that, I want to explain again one concept that normally is difficult to remember. What is 2-sided confidence interval and what is a confidence interval? So if you do 100 measurements to the same patient, one after the other, there will be 5 of them that will be changed just by chance. The 2-sided 95 confidence interval is telling you that if the change that you see is more than these interval that you define, it's more likely that these changes reflect a true pathological change in the cornea. So you can see with reliability that the change is actually significant. And this is what we have inside the software. You can get the E stages for keratoconus progression, but then you need to use also the single parameters to judge, for example, if the patient got stiffer over time. So this is the E staging. You can see that the only thing you can get is no progression or progression because it's a one-sided confidence interval. Instead, when you have the single parameters, then you can have stiffening or no stiffening or no change. Let's see this patient. So this patient is a keratoconus that was showing progression of biomechanics since early 2017. And if you look instead in tomography, that is here, you can see that instead the changes in tomography happened 1 year after. So there was tomographic progression 1 year after. Let's go back. You can see here that already in 2017 there was significant progression in E staging of this patient. This patient was treated with cross-linking, and you can see that there was a significant stiffening of the formation amplitude ratio and also of stress strain index. Again, since it is a one-sided confidence interval, the E staging will not tell you whether the patient has regressed because that is not the aim of the E stages. Now, this is my last slide that is more for your interest because this is not something that you will see very often, but it's incredible. So this is a patient that I recently treated with cross-linking. And the incredible thing is that the E stage went from 3.7 pre-op to 0 post-op. It got so stiff after cross-linking. You can see also all these values were significantly stiffer that even the E staging regressed. This is something very unusual. So this is not something that you will see likely, but I wanted to show it to you to see how reliable this system is. And with this, I thank you very much. So this is the conclusion. E-staging provides information about the severity of the disease and can tell you if the patient significantly progressed. Potentially in the future, we might able, if that will be confirmed by other studies, to decide a cross-linking treatment before tomographical progression based only on biomechanical progression. Thank you very much.
Thank you, Dr. Vinciguerra. Very interesting talk. And I think that last case just shows how it helps the clinician, but I believe also for patient education to show them what you've done with the treatment. This is very helpful for them to understand the treatment and the success of the treatment. I have a question regarding the artificial intelligence, the random forest approach, which is utilized in the TBI. Can you elaborate or explain that a little bit more?
Yes, I can do. Let me see, because I think I have a nice presentation in which I have, just give me 1 second because I have it on my desktop, so it will take nothing.
No problem. I can ask, there's another question I can ask Sven in the meantime. I think Sven, this is regarding the best display. Is it available for all Corvis users?
Yeah, thank you for this question. So the best display is for all Corvis users that do have access to the CBI and TBI software, which is called Dynamic Corneal Response Software. So actually, I think almost any Corvis user does have access to it. And good news for you is that it will be a free update for you. So no costs for this update.
That's always a good thing. Back to you, Dr. Vinciguerra.
So I'm going to try to explain a little bit what is random forest. I have to acknowledge that in the panel, you have one of the biggest experts of artificial intelligence, that is Dr. Abhijit Roy. So you might also want to ask him. So I will try to make it easy because I'm not as smart as Abhijit. Random forest is a combination of decision trees. So we do know more or less what is a decision tree. So you start with one question, and then you put many questions inside inside the decision tree, and based on the answer that you get a result. A random forest is a combination of many decision trees, and the majority of the voting, the average of this decision tree, creates a final result and a final algorithm. So it's a way to create a complex algorithm with, let's say, a simple approach. Maybe also Abhijit wants to say something else.
Sure. So thanks for the vote of confidence, Riccardo. But so to expand on what Riccardo said, I mean, as clinicians, all of you have decision trees in your daily practice. So you have your patient presents with certain features, and you eliminate those features one at a time to reach the diagnosis. So that is maybe one decision tree. Now, if there are 10 clinicians, you know, all the clinicians may have certain variations to their decision trees. And if you take the average of all those decision trees to come to a net decision, a collective decision, whether as far as the diagnosis is concerned, that is simply a random forest. So essentially, you know, a single decision tree is one physician, it's Riccardo. And if you have 10 decision trees, you know, many physicians in Italy working together to diagnose the same patient, and you take the average of those decisions. So 6 of them say, yes, it's progressed, and 4 have said it's not progressed. So you go with the average prediction there, which is the progression. So that's what random forest is in summary. Yeah.
I think I will steal this definition from now on.
Thank you to both of you for explaining this. We have some more questions. One of which is, I have a patient, normal CBI, bad D, final D, TBI, but the DB is greater than 2.6. Why, and do you do surgery for him?
So normal CBI, normal TBI, bad D, abnormal.
Looks like it, yeah.
No. I understand
Oh.
the DB, the back D deviation
the back
value
D.
is only
So the
abnormal.
single parameter in the
So it's
in the
only the back D, and everything else is normal.
Yeah.
Well, of course, you know, it's difficult always to give, you know, one single answer, but in general, my idea is that in Italy we see one single bird doesn't make spring, which makes that if you have one abnormal thing but everything else is normal, to me it's still a normal patient. But if there is something else that makes you think that is abnormal, then is abnormal, that is an abnormal patient, and then don't treat.
Okay, thank you. Another question is, if we reach the level of biomechanical progression that I assume can be cross-linked, then can refractive surgery also be possible for more candidates?
Let's see if I correctly understood the question. So the idea is that if you cross-link the patient before, then you can do refractive surgery? Is that the case? I'm not sure I completely
I'm
understood
also not
the question.
sure understanding it correctly.
Yes. So then the answer is no. Then the answer is no. What I say is, so I think that almost everybody in the world knows what is Pisa leaning tower, right? The tower in Pisa that is leaning, almost going down. So Pisa leaning tower stays like that, and we don't really know how. So that is a patient that doesn't have keratoconus, but is abnormal with biomechanics. You don't know why the patient doesn't have keratoconus, but is abnormal with biomechanics. Just leave Pisa leaning tower alone.
Great explanation. I think the last question that's coming in is, I have a patient with CBI and bad D that is normal, but the TBI show abnormal higher than 0.5. What is the reason for that?
Well, the reason is that CBI and bad D do not simply add to one each other. So TBI is done with random forest of single tomographical and biomechanical parameters. and the TBI has been shown to be superior to BED and CBI for subclinical cases. So if that would be my patient, I would not treat again. I would maybe put an ICL. There are many other ways that you can treat a refractive patient that is not only laser.
Okay, and then I said it was the last, but maybe this is the last one, and then we move on to Professor Li. I have several cases with PMD with normal CBI and TBI. I guess the question is also how many is several cases? What is your explanation?
Well, the explanation to me in this case is fairly simple. The CBI in pellucid marginal degeneration is very far from the center. So we do know from keratoconus that the abnormality of biomechanics is focalized in the area of the corn. The rest of the cornea is normal with regards to biomechanics. So if the Corvis is evaluating the central part of the cornea, then you are evaluating a part that could be normal with regards to biomechanics. So that's the reason.
Thank you very much, Dr. Vinciguerra, and thank you also for your very informative talk as always. We appreciate it. Our next speaker is Professor Lim Li from Singapore, and she's going to talk about pre-operative evaluation for refractive surgery with Pentacam corneal tomography and Corvis ST. Now, Professor Li has recorded her talk for us, so I'm going to share the video. Just one technical thing, in the WebEx, the video is not necessarily shared very big, but you have the possibility to change the size of the video in your screen yourself. So let me see that I can share the talk, the recording. And then after the talk, we will have a chance for you to ask questions to Professor Li as well. Okay, it's opening, it's opening.
Good evening, friends and colleagues. I would like to thank OCULUS for the kind invitation to speak today. I will be speaking on pre-operative evaluation for refractive surgery with Pentacam corneal tomography and Corvis ST. Here are my financial disclosures. Corneal ectasia after LASIK is one of the most devastating complications after corneal refractive surgery. More than 50% of these cases are attributed to unrecognized preoperative frunctus keratoconus, FFKC, and subclinical keratoconus. There is a higher incidence of keratoconus in refractive surgery candidates of 5.7% in some reports. Hence, preoperative diagnosis is critical in preventing the development of post-LASIK ectasia. In my talk, I will go through with case examples the corneal refractive surgery screening process with the Pentacam tomography and the Corvis ST. For the Pentacam, the 4-maps refractive display and Baleen Ambrosio Enhanced Ectasia Display, BAD, are useful for refractive surgery screening. And for the Corvis ST, the biomechanical tomographic assessment report is useful. As we all know, keratoconus is a progressive non-inflammatory disorder resulting in thinning and protrusion of the cornea. Posterior corneal and pachymetric changes are seen in the early stages of ectasia, which makes rotating Scheinflug imaging very useful in diagnosing early ectatic change. Pentacam imaging is an elevation imaging system able to look at the optical cross-section. Hence, it is able to generate elevation maps of the anterior and posterior corneal surfaces, keratometric maps, and pachymetric maps of the cornea. This is different from the Placido system, which is a reflective system, looking at the anterior corneal surface. Currently, at the Singapore National Eye Centre, we use the 4-maps refractive display for screening of refractive candidates as recommended by Professor Baleen. Here is an example of the 4-maps display. The top left is the anterior elevation map, top right, posterior elevation map, bottom left, the keratometric map, and bottom right, the pachymetric map. The elevation maps are displayed using a best fit sphere of 8 mm. The reference sphere surface is green in color. The steep profile falls below the reference surface and is colored blue. Hence, this cornea has a steep curvature at 90 degrees. The flat profile rises above the reference surface and is colored yellow to orange. According to Bailyn, an anterior elevation of less than 12 microns is normal and more than 15 microns is suspicious of keratoconus. Likewise, for posterior elevation, less than 17 microns is normal and more than 20 microns indicates keratoconus, especially if there is a central posterior elevation noted. The elevation maps shown here are normal. For the pachymetric map, an off-center distribution is suspicious. This particular map has a normal distribution. The curvature map is color-coded opposite to the elevation maps. The warmer colors of yellow and orange indicates a steeper curvature, and cooler colors of green and blue indicates flatter curvatures. This color coding is similar to other topographers. This map shows a normal with the rule astigmatic cornea with the vertical bow tie pattern. The second display is the Bailyn-Ambrosio display, or BAD. This diagram explains the concept behind the enhanced display. This figure shows the normal best fit sphere versus the enhanced reference sphere, which excludes the central 3.5 mm area around the thinnest location to accentuate the ectasia. So as you can see here, the ectasia is being enhanced by the enhanced display. For example, the top figure shows a normal cornea where the standard best fit sphere and enhanced best fit sphere are within the normal range. The bottom figure shows an abnormal cornea where the enhanced best fit sphere enhances the abnormal ectatic change in the posterior corneal surface. This is the Bailyn-Ambrosio display and consists of two portions. The left are elevation maps and the right are pachymetric progression charts. For the elevation maps, the top two maps show the front and back elevation with the standard best fit sphere. The middle two maps show the front and back elevation maps of the enhanced display, and the bottom two maps show the difference between the two. This example here shows a normal display. The pachymetric charts consist of the corneal thickness spatial profile chart, which shows the average thickness of the cornea from the center to the periphery, and the three black lines indicate the normal mean corneal thickness with 95% confidence intervals. The percentage thickness increase shows the same data, but as a percentage increase from the thinnest point. This example is also normal. This is an abnormal display with the enhanced map accentuating the abnormal posterior elevation here. The difference map is color-coded, and the red on the posterior map indicates more than 16 microns difference, and yellow is between 12 to 16 microns difference. Here is an example of a keratoconic eye with abnormal CTSP and PTI charts, with the red line dropping below the normal curve. The average progression index of the normal cornea should be less than 1.2. Another novel pachymetric parameter is the Ambrosio relational thickness, ART average and maximum, with AUC of 0.987 and 0.983 respectively. The ART index is obtained by dividing the thinnest point by the pachymetric progression index. At the bottom of the BAD display are 5 parameters with a final D value. The final D index is predictive and separates normal from abnormal cornea. The final D value is based on regression analysis of 9 parameters, including these 5 parameters you see here, as well as anterior and posterior elevation at the thinnest point and Kmax. For the final D value, the normal is less than 1.6. Subclinical keratoconus and forme-fruste keratoconus are different conditions. Subclinical keratoconus is defined as having topographic signs of keratoconus, but a normal slit lamp examination and keratoconus in the fellow eye. Forme-fruste keratoconus, however, has a normal placido topography, normal slit lamp examination, and keratoconus in the fellow eye. Studies have shown that Pentacam parameters are sensitive in diagnosing subclinical keratoconus, but might not be as sensitive in diagnosing forme-fruste keratoconus. For example, in this case of a 36-year-old Chinese male with right eye keratoconus, in the right eye, the Pentacam 4-maps display shows obvious signs of advanced keratoconus with Kmax of 69 diopters, raised anterior and posterior elevation maps corresponding to the inferior steepening pattern seen on the keratometric map, and thinnest pachymetry of 411 microns. And the BAD also displayed obvious signs of keratoconus. In the fellow FFKCI, the tomography is normal with normal anterior and posterior elevation maps, normal keratometric and pachymetric maps. And the BAD is normal with a D value of 1.37. Hence, in this fellow FFKCI, Pentacam tomography is unable to differentiate it from normal eyes. From the previous case example, you can see that form fruit keratoconus eyes may be missed with tomographical methods of screening. Hence, combining Pentacam with biomechanical methods such as Corvis ST may provide safer and more efficient refractive screening. The Vinciguerra screening report is a screening tool for the biomechanical properties of the cornea. It has the different dynamic corneal responses parameters shown here, such as the DA ratio, the HC radius, the ARTH, as well as the stiffness parameter. These parameters are expressed as standard deviation from the regression. The CBI is the one parameter derived from the 4 parameters. Vinciguerra et al. Reported that CBI was able to detect keratoconus with an AUC of 0.99. For ectasia screening with CBI, in normal eyes, the CBI is very close to 0. In ectatic eyes, the CBI usually is close to 1. Between 0.2 to 0.8 represents moderate risk for ectasia. Vinciguerra reported that the CBI cutoff for LASIK screening is 0.5. By combining raw data from Corvis and Pentacam, another new index, the Tomographical Biomechanical Index, or TBI, is calculated by the Corvis software. A TBI of less than 0.3 indicates a low risk of ectasia. The TBI cutoff for LASIK screening is 0.29. In the following slides, I will show you case examples of LASIK candidates. This is a 41-year-old Indian male with manifest refraction of about -3.75 sphere in both eyes. The 4-maps refractive display shows normal anterior and posterior elevation maps in both eyes, normal pachymetric maps with minimal corneal thickness of about 550 microns in both eyes, and normal topography maps in both eyes. The BAD is normal in both eyes with a normal enhanced display. You don't see any hot spots, and a normal D value of 0.29 in the right eye and 0.31 in the left eye. For the Corvis report, the CBI is normal at 0.23 in both eyes. The cutoff for CBI for LASIK is 0.5. The TBI is also normal at 0. The cutoff for TBI for LASIK is 0.29. Hence, this patient is suitable for all refractive procedures such as LASIK, surface ablation, and SMILE. This is a 24-year-old Chinese female with a manifest refraction of about -3 sphere and -1 cylinder in both eyes. The 4-maps refractive display shows normal anterior and posterior elevation maps in both eyes, normal pachymetric maps with minimum corneal thickness of about 550 microns in both eyes, and a normal bow tie pattern topography maps in both eyes. The BAD is also normal in both eyes with a normal enhanced display and a normal D value of 1.17 in both eyes. For the Corvis report, the CBI is 0.39 and 0.41 in the right and left eyes and is within the cutoff value of 0.5. The TBI is 0.01 and 0.13 and is within the cutoff of 0.29. Hence, this patient is suitable for all types of refractive procedures. This is a 25-year-old Chinese male with the manifest refraction of -4 sphere in both eyes. The 4-maps refractive display shows normal anterior and posterior elevation maps in both eyes, normal pachymetric maps with minimum corneal thickness of about 580 microns in both eyes, and normal bow tie pattern topography maps in both eyes. However, the BAD shows a suspicious posterior elevation on the posterior enhanced map in both eyes. The CTSP and PTI are normal, and the final D value is 1.04 and 1.47 in the right and left eyes. The Corvis report shows that the CBI and TBI is normal in both eyes, indicating normal biomechanical parameters. Hence, this patient is suitable for refractive surgery. OP-scan topography was performed to confirm the Pentacam findings. In the OP-scan, you can see that the posterior elevation maps are also raised. But as the Corvis parameters indicates that the corneas have normal biomechanical properties, this further adds to the safety of refractive surgery for this patient. Another case example is a 23-year-old Chinese male with a manifest refraction of -3 diopters in both eyes. The 4-maps refractive display shows normal anterior and posterior elevation maps in both eyes, normal pachymetric maps with minimum corneal thickness of about 510 microns in both eyes, which is below the average thickness, and a normal bow tie pattern topography maps in both eyes. The BAD is also within the normal range with normal CTSP and PTI. The D value is 0.86 and 1.18 in the right and left eyes. However, the Corvis test shows that the CBI is high at 0.94 in the right eye and 0.61 in the left eye. The TBI is within normal range of 0.16 in the right eye and 0.29 in the left eye. In view of the abnormal CBI values indicating ectasia susceptibility, surface ablation is recommended for this patient as LASIK or SMILE may result in higher risk of ectasia. The last case is a 38-year-old Chinese female with a refraction of -6.25 sphere and -1.25 cylinder in both eyes. The 4-maps refractive display shows normal anterior and posterior elevation maps in both eyes, normal pachymetric maps with minimum corneal thickness of about 523 and 517 microns in the right and left eyes, and normal bow tie pattern topography maps in both eyes. The BAD is also within the normal range, with normal CTSP and PTI. The D value is 1.29 and 1.05 in the right and left eyes. However, the Corvis report shows that the CBI is high at 0.54 in the right eye and 0.71 in the left eye. The TBI is within normal range of 0.04 in the right eye and 0.01 in the left eye. In view of the abnormal CBI values indicating ectasia susceptibility, this patient is advised against LASIK or SMILE, and as her myopia is higher than -6 diopters, surface ablation is also not recommended. OP-scan topography also confirmed that the corneas were thin, with thinnest pachymetry of 507 microns in the right eye and 490 microns in the left eye. In conclusion, combining Pentacam tomography with Corvis ST provides for safer and more efficient refractive surgery screening. Thank you for your attention.
Thank you very much, Professor Lee, for this interesting and comprehensive talk. I do have a question for you. What would you say, what's your criteria to decide which treatment to do for which patient? Because you mentioned patients not suitable for LASIK or SMILE, but rather surface ablation. So what's your cutoffs, and when do you decide to do what treatment?
So, for example, if you have a normal tomographic maps and normal biomechanical parameters, then the patient would be suitable for all three, whether it's surface ablation, LASIK, or SMILE. But if let's say the patient has some abnormal Corvis parameters, and then but it's still if the myopia is low, all right, and you need to evaluate everything together, like maybe the age of the patient, and look at the Pentacam parameters. The cornea is fairly thick and not too thin, all right. I think there is a possibility of doing a surface ablation. Definitely, you need to avoid LASIK if the Corvis parameters are abnormal. But there is a possibility that a patient can still do a surface ablation.
I think this carries on from that question that's coming in. You mentioned surface ablation as the preferred to SMILE or FEM to LASIK for the case with the bad CBI but normal TBI. Please explain how surface ablation that removes stronger stroma is more safe.
Yeah, you avoid making a flap. That's basically the reason. So you only, yeah, of course, well, I suppose there's an argument that when you laser on the surface, you may remove the stronger fibers that is on the surface of the stroma, right? But if you do a flap, that's worse, right? You truncate the whole, 100 microns of the anterior stroma. So if you compare surface ablation and LASIK, definitely I would prefer surface ablation for its, I think it's more biomechanically stable than compared to LASIK and SMILE.
So I just would like to add to that thought from Dr. Lim. So the question is why you would consider surface ablation superior to SMILE or LASIK in these cases. So first of all, biomechanically, the contention was that with SMILE and LASIK, you leave the stronger part of the cornea a lot more intact than obviously PRK removes it completely. But the underlying premise in that logic was, I think, a little bit flawed, because once the flap or the cap is or the cap is cut, that portion of the stroma doesn't bind itself to the residual stromal bed in any way. So even now there is no clear evidence if the collagen fibrils in the anterior portion of the stroma get recruited to bear the mechanical stress due to the intraocular pressure post-operatively. So even though you may leave the anterior portion of the stroma intact in SMILE or LASIK, there's no clear evidence to support that that portion of the stroma still is bearing the stress post-operatively. Therefore, under these scenarios, it's always better to go with PRK, because PRK has certain biological advantages also. We do know that there is some amount of subclinical scarring that gives a biomechanical strength to the cornea, and therefore it's beneficial for these cases. But again, you should not push your luck too much, because if you, like Dr. Lim rightly pointed out, that if the refractive error is too high that you want to do, then definitely you should not even go with PRK. Dr. Rohit is also there in the panel. I don't know if he wants to add any additional.
It's of course.
Prof Lim covered it beautifully, and you have explained it. I think it kind of summarizes it. When in doubt, don't do anything. ICL would be the best thing to go always. But when you know that you're still debating based on the imaging, when you're clear cut, no clear definition or no clear path, then I think PRK would always be the best one.
So of course, great having here in this panel both the biggest biomechanical experts and the clinical experts. So one can combine this information. In terms of ectasia risk, I also heard the numbers that I think about 95% 5% or so of post refractive surgery ectasia is either LASIK or SMILE, and much less PRK. I don't know whether you have some numbers also, Professor Rohit, perhaps, whether you know some numbers how frequent ectasia is
I think
LASIK. And
there are reported case of PRK ectasias, but unlike LASIK or SMILE, there is no big study which looks at big numbers of ectasias in PRK. So it just makes us a little more comfortable that probably could be some beneficial way of how it's going to prevent. And when there's one challenging aspect we also see in SMILE is a lot of published cases of SMILE where topography looks very much normal. Then these are the patients sometimes develop ectasia. These are the ones where we have to be very careful about. Today's imaging technologies are fantastic. They usually pick up these subtle from first kind of subclinical cases. But the challenge for us is about picking up those who look very normal on topography, but they may be biomechanically unstable and they develop ectasia. And these are all big challenges which we have to be very aware of.
On that note, can any of you comment on this question? Do you have any cases where you cannot do LASIK, but you can still do SMILE?
As a clinician, if I take this question, where I don't want to do LASIK, I would not do SMILE. And we have published work on this, and which backs my statement here is if both LASIK and SMILE have very similar biomechanical stability after 6 months, I don't see that one is going to be much superior. I mean, many times experimental models have shown some change, but in vivo work which we published in GRS clearly demonstrate after 6 months is hardly any difference. So if you're looking at biomechanical instability or weakness, both have the equal amount of risk.
Yes, I agree. I agree with Dr. Shetty. Actually, the criteria for LASIK and SMILE eligibility is very similar. So it's the same group of patients.
Thank you, Professor Lim, Professor Shetty. On that note, Professor Lim, thank you also for a fantastic, like I said, comprehensive presentation. We appreciate it. I think now we will move on to the last presentation, which is a combined presentation by Dr. Roy and Professor Shetty, which is going to introduce and talk about the software AcuSim X. Dr. Roy, you are the presenter, so you can start sharing your screen.
Dr. Abhijit is the presenter. I'm just the co-host here.
Perfect.
I'm just put this on full screen. Okay, so thank you for this opportunity. We are very delighted to share our, this is like really one of our initiatives when it comes to imaging, biomechanics, AI related to the cornea and refractive surgery at Narayana Nethralaya, and very glad to get this opportunity today. So today I'll be presenting our latest tool, which is called the AcuSim X. This is really a tool that has been designed to put the power of predictive simulation at your fingertips in your OPDs, so that surgeons can just run them and analyze these cases with very sophisticated biomechanical tools. Special thanks to the funding agencies, Indo-German Science Technology Center. OCULUS has been helping us for several years, and without their help, this would not have been possible. A lot of clinicians at Narayana Nethralaya, as well as Dr. Prema and Dr. Riccardo. Dr. Riccardo is also one of the panelists, have been very instrumental in the validation of AcuSim X. So, as far as in vivo corneal biomechanics goes, the Corvis ST is the tool that is available to us currently at the clinic. And in combination with Pentacam, several other indices have been brought into the market. So you have indices such as BAD-D, TBI, CBI, SSI, and these together assist the clinicians in getting an objective view of the current tomographical as well as biomechanical status of the cornea. However, one of the things that is still lacking is that we cannot predict what the post-operative biomechanical status of these parameters would be, once a surgery is done. So you can even have a normal cornea at the preoperative stage, and maybe you would be doing a very high refractive error treatment on this eye, and therefore it still leaves some amount of doubt in the minds of the clinician. So it can be a normal CBI, TBI, but it might be a minus 7, minus 8 treatment, and therefore you're always concerned to a little bit that, okay, this is a high refractive error treatment, and therefore will the cornea be stable even post-operatively? So therefore there is some room left still to bring about some predictive tools which can be used right at the preoperative stage, which can tell you what would be the biomechanical property or the biomechanical stiffness of the cornea at the post-operative stage. And therefore, keep this in mind that we are trying to give these predictions right at the preoperative stage. So recently, Dr. Riccardo, he was one of the panelists, came up and these co-authors came up with this paper where, post LVC, they have come up with another an algorithm basically to determine, which eyes are stable after laser visor correction and which eyes probably are showing ectatics, symptoms after surgery. And the results showed that they had pretty good sensitivity and specificity in detection of eyes that were tending towards ectasia, whereas eyes which were stable after post laser vision correction. And keep in mind that this assessment is done after surgery. But again, this analysis can be done only after the vision correction is done, and therefore still 100% detection is kind of elusive at this point. Therefore, there is still the room, and therefore it still becomes very important that if we could do the risk assessment at the preoperative stage and the appropriate choice of surgery. And in order to do this, we do need advanced simulation and tools, which can be used at the clinic in real time. So here's an example of a patient, 26-year-old female. The tomography maps you can see here, the refractive errors that the patient had are also listed there.
The slides are moving now. Sorry, the slides were not moving then. Now it's okay. Now it's okay.
Yeah. So so you can see that this is the refractive error of the patient in the right eye and the left eye, and the corresponding BAD-D, CBI, and TBI values are there. And as you can see that these are pretty much in the normal range, nothing much to worry about. Smile surgery was done on this patient. However, after 3 years, after 3.5 years, the patient presented with ectasia. So, so this was exactly the point I was trying to make, that you can have certain challenging cases where everything looks okay preoperatively, but sometimes the refractive error can be slightly on the moderate to higher side, and the patient still ends up with ectasia after surgery. And therefore, these are the cases where we would like to bridge the gap, and with the help of advanced simulation tools, and that's where AcuSim comes into play. So this is where we came up with this specific set of tools many years back, where we introduced surgery specific modeling. So what does this modeling mean really here? So we have developed biomechanical simulation models where we not only take into account the in situ collagen fiber distribution that exists in patient corneas, but we also look at the contribution of epithelium, the contribution of Bowman's layer, and the contribution of collagen crimping into these sophisticated biomechanical tools. We published this article many years back in 2018, where these biomechanical models were described in detail. But like I said earlier, these models, if you expect the clinicians to run them in their clinics, is virtually impossible, because they cannot be expected to, build, develop, and run these simulations at your end. And therefore, we came up with this idea of including all of this in one software package, which we call the AcuSim. So the AcuSim takes into account the three-dimensional corneal geometry, which is measured by Pentacam. It takes into account the Corvis ST measurement. And using this, we do something known as finite element modeling, which models the biomechanical deformation of the cornea. So we have these real-time videos playing, which shows how the cornea deforms when the air puff is applied. And from this set of models, we derive what are the true biomechanical properties of the cornea. But again, those properties by itself are not very useful to the clinician, because you want to know what would be the status of the cornea post-operatively. And that is where, when we include the planned refraction, the type of surgery, the flap cap settings, the optical zone size into those three-dimensional geometries, and conduct surgery-specific FEMs, that is surgery-specific models. Because why do I say surgery-specific? Because you have three different platforms available. You have SMILE, you have LASIK, you have PRK. So you can simulate each of those surgeries in the software to determine finally at the end what would be the post-operative corneal stiffness. And that stiffness would help you select the appropriate surgery for the particular patient. Another advantage of this whole process is that you have determined what would be the corneal stiffness at the preoperative stage. So when you actually do the surgery on the patient, when you measure the patient post-operatively, you can check if the corneal stiffness that the patient ended up with post-operatively, how well does it compare with the prediction from the software. And that gives you that added confidence that the patient's cornea is responding biomechanically as per the expectation, as per how the scientific evidence. So to describe this software in nutshell, I want to showcase these two figures. So the top left-hand figure shows what was measured preoperatively and what the software estimates. So that is intuitively quite straightforward, because it's been measured. The software should be able to capture the same deformation accurately, and that is what it shows there. The solid lines are basically what was measured, and the dotted lines is what was simulated by the software. But the key figure here is the figure on the lower right hand side, because this is where the post-operative deformation of the cornea was compared with what was predicted by AcuSim. So the solid lines again describe what was measured on the patient's cornea post-operatively, and the dotted line shows what the software predicted at the preoperative stage, taking into account the refractive error, the type of surgery, the surgical settings such as flap cap diameter, thickness, etc. So this is the true power of AcuSim, because you are able to simulate the post-operative deformation amplitude right at the preoperative stage, and therefore you can choose the appropriate surgery for the patient. So this is basically the first window that comes up when you open up the software. We call it really, this is the first finite element simulation and AI-based prediction tool that is available for corneal refractive surgeons. It's a very user-friendly design. You can easily deploy it in routine computers in the clinics. We have surgery-specific models, which are SMILE, LASIK, and PRK. And we have the power of sophisticated biomechanical simulation using finite element methods put right into this one software. So all you have to do is read the Pentacam and the Corvis ST measurement files into the software, enter the surgical settings such as you can see, the thickness, diameter, optical zone, IOP, the intended refractive error that you want to treat, so spherical cylindrical power, axis, and the epithelial thickness. And then all you do is add to run queue, that button which you see on the right side, and the simulations run in the background. And you can queue up multiple simulations at the same time. So if you have 10 patients that you want to do, you just read all the files one at a time and just leave the software to run. This is the patient data interface. So once the simulations and the predictions are completed, you can read the reports from this window, and you can keep a PDF of the report stored on the computer, or you can even print it out. So this is how the simulation report looks like. So on the left is the report. We have blanked out the patient information, but what we have are those two very important figures. Okay, these are basically this, population histograms of the preoperative data of a population of eyes. And then those same eyes, when operated, what was the distribution of corneal stiffness that they ended up with. And if you are simulating a particular eye, those two vertical black lines actually tell you what was the preoperative stiffness, and the second black vertical line shows what was the predicted postoperative stiffness. So you have the preoperative measurement and the predicted postoperative measurement plotted on the same figure. And as you can see, for this particular patient, they predicted the measured preoperative corneal stiffness was at the preoperative stage was around 100, whereas the predicted postoperative corneal stiffness was around 90. And we also have given the confidence interval of the prediction so that the clinicians can evaluate. in the latest version of the software, we also have an ectasia risk assessment report. So we were very fortunate to get at least, currently we have a set of 10 eyes for which we have both the pre and the post-operative Corvis measurements. So that's very challenging because it's always very difficult to get pre-operative measurements. I was talking to Riccardo during the validation stage of the software, and he said that they rarely get the pre-operative measurement for the LVC cases. So so we were very fortunate to get these 10 cases where we also had the pre and the post, and using the pre and the post-operative measurements and the software predictions, we have come up with this very nice ectasia risk assessment report where you can assess based on the predictions by the software, which is a case of a normal stiffness post-operatively, which is a case of low risk of ectasia post-operatively, and then moderate as well as high risk. So if the prediction of corneal stiffness, if the prediction of corneal stiffness after surgery falls within the normal stiffness range, then the green button will show up. And if the prediction of the corneal stiffness at the post-operative, if the prediction of the post-operative corneal stiffness falls in the low risk or moderate risk, then definitely, we would eliminate LASIK or SMILE from the treatment possibilities. In that case, PRK or PRK extra would be the only possible options. Okay, and if the eye falls in the high risk, then it's a definite no. So like Dr. Lim also mentioned, like she was talking about refractive error of 6.5 diopter as one of the cutoffs for PRK. And as you can see in our nomogram, it was also picked up based on the predictions that, if you are exceeding that high power, then you probably should not be doing any of the surgeries on that particular eye. So this assessment report is also available in the software, and it can be printed out as a report for a given eye. So have we validated the findings? Yes. Wish to thank Dr. Shetty, Dr. Prema, Dr. Riccardo very much for providing us with a large database of cases. So where, as you can see, it was over 529 eyes. And and as you can see that if you compare the in vivo, that is what was measured post-operatively versus what was the prediction, that is the AI, there was almost a 1:1 correlation. And most importantly, the software was also able to identify those 10 eyes that is indicated by those red dots there, red circles there, that that at the pre-operative stage itself, the software was able to identify that these eyes would end up with ectasia. Here are some case examples. The top two, where you can see it's listed as PRK and SMILE. Here you can see that the software actually told you that if the eye underwent SMILE, then the intended change in the corneal stiffness would be 2.6 times more than PRK. So therefore, PRK would be the obvious choice. On the lower left-hand side, we have another patient titled as subject 1. And as you can see that for the left eye and the right eye, the CBI and TBI were very much normal. But what is very interesting is that if you look at the right eye preoperative corneal stiffness, it was around 70.81, whereas for the right eye, the preoperative corneal stiffness was 88. So as you can see that there is asymmetry between the two eyes, and the right eye would have definitely failed our ectasia risk assessment nomogram. Therefore, this patient should have not been operated at all, and that's how the software has picked it up. Similarly, there is another subject here, which is subject 2, and here also you can see that the right eye and the left eye have pretty much normal CBI, TBI. But once again, if you look at the corneal stiffness that is being derived from our sophisticated models, it's around 79 for the right eye, and it's around 85 for the left eye at the preoperative stage. And again, this is a flag because of the asymmetry of the measured corneal stiffness between the two eyes at the preoperative stage. And of course, once again, the right eye would have failed our ectasia assessment using the software. So I would like to present one more interesting case. So this is one patient who came, visited Dr. Shetty's clinic in 2016 and again in 2021. In 2016, as you can see, the topography looks pretty okay. The CBI, TBI were also fine. However, when the patient again came in 2021, as you can see that the patient had ectatic changes. And at that time, obviously, there was no AcuSim also. However, we could retrospectively assess this particular patient's eye. And as you can see that at the preoperative stage, the preoperative corneal stiffness was 83, which again failed our, sorry, again, there is some power loss, apologize for it. Can you still see the screen?
Yes, we can.
Okay, great. So I'll continue. So you can still see that this patient actually came up with the low risk of ectasia at the 2016 time point. So this is a so basically this is a flag that this patient probably can end up with ectatic changes, and therefore the risk assessment of doing surgery should be carefully evaluated. You know, again, the question is coming up that should you be doing PRK on these eyes, maybe to stabilize the cornea? That's something, you know, open to debate all the time. But nonetheless, at the 2016 time point, the software accurately showed that there is a risk of ectasia, although it was low. So what's next in the AcuSim platform? So first, we have shown a refractive module where we could use the software to predict what would be the post-operative corneal stiffness, and therefore understand what ectasia, whether the eye would end up with ectasia. And therefore, we want to expand the world of biomechanics into how we can refine corneal cross-linking. So this is an example of a keratoconic eye. It's a Pentacam map. And what the software actually gives, this is in the research domain right now. This is not available in the commercial module. So as you can see here, we have come up with a sophisticated module where we can map out where the biomechanical degeneration in the cornea is. So the bright red zones that you see in the map, that on the color map, which is on the right hand side, indicates where the cornea is biomechanically very weak, and therefore you would like to target the UV beam to these zones specifically, so that the maximum benefit of corneal cross-linking therapy is delivered to these zones. So this is going towards true customization, because you're not relying completely on tomographic features, but you're actually looking at the biomechanics. Once again, the bright red zones indicate where the cornea is the weakest in this particular patient's eye. And as you can see that it doesn't really match the topography that is shown on the left-hand side. So what happens when you focus the UV beam specifically to the central cornea, as you can see, and specifically to the shape and size of that zone? This is what you get. And so the preoperative corneal topography map is there on the first column. When you look at the post-operative map, you can see how clearly and how nicely the cornea has remodeled. In fact, you know, it's almost come back to what you would see in a normal patient. And what's most important is that if you target the biomechanical degeneration zones, you actually preserve the astigmatism very nicely. So there is scope to refine the algorithms further, where you can titrate the astigmatism that the patient can end up with. And if you do the pre minus post comparison, that is what is shown up in the left hand side. So what is another USP of doing simulation based corneal cross linking therapy is that in this particular patient, we used an UVA energy density of 4.63, which is even lower than what is used in the Dresden protocol. The Dresden protocol is 5.4. So you have the scope to make the corneal cross-linking therapy more safer. So we have conducted a pilot study using the AI-driven corneal cross-linking therapy at Narayana Nethralaya with the assistance of Dr. Rohit Shetty. We have a manuscript which is under review. Since the AcuSim is now available for the customers of Oculus who are using both Pentacam and Corvis to use in their clinics. You know, one of our users, Dr. Brendan Cronin from Queensland Eye Institute, was very interested in trying this out. He's using it for refractive anyway, and he wanted to do another pilot study. And therefore, we are supporting him with this study using our AI-driven corneal cross-linking. Another USP of doing this next pilot study is we are testing an epi on an oxygen supplementation, and therefore, you know, we should have results maybe in around the 6 months with respect to efficacy and efficacy of this treatment compared to a regular corneal cross-linking therapy where you target tomography features only. So with this, just like to give a brief description of the requirements. All these details are available in the manual, but to sum it up, AcuSim can be run on routine computers. You don't need supercomputers to run this software. Standard Windows machines that are available in clinical OPDs can be used to run AcuSim, and there are really no super specific requirements to run these sophisticated models. With this, I'd like to conclude, and if there are any questions, we'll be happy to take them. Thank you.
Thank you very much, Dr. Roy, for this interesting talk. I'm sure everybody benefited and learned a lot. A question, this is more related to the technical. You mentioned the data from the Corvis and the Pentacam going into the software. Is it automatic transfer or is it manually typed in? How does it work?
So currently, both the Pentacam as well as the Corvis software gives an option to export a certain file. Once that file is exported, you can read those files through the software, and the software does everything in the background. That's it. So the software pulls in the patient information like the medical record number, name, gender, all the Corvis and the Pentacam measurements automatically from those files, and you can just start running the simulations. So in future, and I think Sven can comment on that also, that we will include an option where we can also skip the export process. So the software would be able to link to the Pentacam and Corvis softwares directly, so that even the exporting option is eliminated. Sven?
Yeah, actually, that's true. I mean, we have these external software links in the Pentacam software currently, so that you start the software from the Pentacam software, and then it takes all the data that are needed. Here, of course, the software would require data from both instruments, so we need a little bit of different linkage, but that will be available certainly in the future, but I cannot promise you exactly the time point.
Okay, let me just check if there's any other questions coming in. Let me just see if you have any more questions. Please write it in the chat function. Sven, do you have any other questions or comments about?
No, I mean, it's a presentation. I think really it shows very nicely, as Abhijit pointed out, how supplementary this software tool is. I mean, where the Corvis can provide really the nice screening functions pre-operatively with CBI, TBI, but indeed you do not have information about post-operative stiffness, because you cannot add the refractive change, and this missing part is really brought to this very, very nice software. And yeah, it's a really fantastic work by Abhijit and Rohit and this group.
So just to add to Sven's comment there, so like he said, so I just would like to give an example. You can have a cornea with a CBI of, let's say, 0.3, and 0.3 is a number that may be of concern to some, may not be of concern to some other clinicians. But let's say two corneas having a CBI of 0.3. One cornea needs a refractive error treatment of -3, whereas the other cornea needs a refractive error treatment of -5. And that's when the question comes. -3 may leave the cornea with still an acceptable CBI post-operatively, but -5 may not. So those are the scenarios where the software is going to bring in additional value. And if the cornea is thinner than the usual ones, so if you have a 500 micron cornea and with a CBI of 0.3, one needs a refractive error treatment of -3 and the other needs a refractive error treatment of -5, -6, that is when you would like to come up with these predictive simulations, because these simulations will tell you what would be the predicted stiffness post-operatively and whether that predicted stiffness falls within the ectatic range. So again, software is very easy to use. Like I said before, the entire sophistication is at the back end, and for the clinicians, it's as simple as reading the Corvis and the Pentacam measurements, inputting the surgical parameters, and that's it.
Thank you very much for that explanation, Dr. Roy. I think with that, there's no more questions coming in, so I would like to conclude this session. first of all, one question, last question. Where do I get the software?
So currently the entire distribution of the software is being handled by Oculus. So please get in touch with them.
Thank you for that answer.
Yeah.
So again, thank you to everyone for preparing and presenting today from Singapore, India, and Italy. We appreciate the time and effort. Thank you to all of you who attended this session. We appreciate your time, and I would like to wish you a very good evening, good afternoon, good morning, wherever you may be. Till next time. Bye-bye.
Bye-bye. Thank you. Thank you.